Nancy Reau from Rush University Medical Center in Chicago, and I'm really excited to be at the CLDF 4th meeting here in Scottsdale, Liver Connect, and I'm joined with two of my excellent colleagues.
Hi, my name is HoChong Gilles. I'm a nurse practitioner at the Richmond VA Medical Center.
And I'm Christina Hansen, family nurse practitioner at South Denver GI, and this is my 4th attendance to CLDF Liver Connect as well, so it's very fantastic to be here.
Thank you both for joining me. So we just completed the cirrhosis section. And so I'm going to start by one of the more common liver complications, hepatic encephalopathy. Can you tell me a little bit about how you counsel your patient who's been found to have hepatic HE, kind of that first time?
Yeah, so I think there's a lot of a need for education, not only to the patient themselves, but to their family members, because a lot of times it's the family member that notices changes, even subtle changes, more than the patient. You know, we like to joke, the patient's happily confused. And so they may not know that what they don't know. And so involving those family members, significant others, just the signs and symptoms to watch for, I think is really important to talk about precipitating events or precipitating factors that could make them at risk for a recurrence. Notably, if they do have ascites and they're taking lactulose, for instance, dehydration and overusing lactulose can be one of the big risk factors, when you think about community, but infection, so on and so forth. So talking about risk factors, signs and symptoms involving family members on what to watch for.
That's perfect.
I completely agree with you, Christina. I think that, some of the symptoms that, family members always say is that there's personality changes,
Mm-hmm.
right? So one of the other important aspects in practice, I think, is, especially when you're talking to perhaps somebody with active, HE, it's difficult to get a good medication list. And so this is where their family members are so important. And, looking at all the medications in addition to, discussing the precipitating factors that you mentioned, because it's, some of the medications could also be contributing.
Mm-hmm.
And then I do like when Dr. Gordon was talking about the list, not to really pay attention and give explicit directions to the family members as well. So I do actually have a handout that we give to titrate, lactulose, because I think that's often very confusing to the patient, but also the caregiver. So it's important that they're all on the same page.
Absolutely. And educating on what the treatment's for. How many times do we see a patient come in, maybe a new patient to our practice, but with first onset HE from, a hospital admission. So it's a follow-up from an admission. And just the ideas around lactulose, for instance. Well, I'm not constipated. What is this actually doing? Explaining to them, having that education. Actually, this is to help, in layman's term for the patient and their significant other. This is going to help clear your brain. And then they're bought in. Oh, I get it. But what is this for? Having that understanding of why it's necessary. And no, it's not just treating constipation. It's actually treating the HE, and this is why. So having that education around why it's important to take it.
So, HoChong, how about compliance? Because one of the things I think we find and family members find is the patient stop their medication.
I always talk about cirrhosis, and the burden of cirrhosis is a huge economic factor. And, when even they have caregivers or spouses, they work. And I think it's very difficult if you don't involve the family. But I think that patients themselves, they don't want to be like non-adherent to lactulose administration. But I think that, a lot of side effects like the bloating, or they get too frequent stools or having diarrhea to the point that, they just stop. When they travel, I think is all, I always have patients that come to me for liver transplant evaluations. When they travel a distance, they, stop their lactulose and they present to their liver transplant evaluation overtly, encephalopathic, which is always challenging. So I think that we really have to kind of, in a multifactorial way, address compliance, but also the side effects, advise them also the tremendous impact on, daily living, like driving, because they shouldn't be driving, just a lot of counseling in general. But adherence, I think, is difficult when folks are, by themselves, when they don't have a lot of adequate support, and that could be very challenging in clinical practice.
Christina, the session concentrated a lot also on refractory encephalopathy. Recurrent encephalopathy, I think, is quite common. How often are you finding a patient who is truly adherent? You eliminated exacerbating, concomitant risk factors, and they are still struggling with confusion.
Yeah, that's a really good question because I thought the session was really compelling on talking about what really is refractory. And you spoke a lot about, is it really or is it not, non-compliance, precipitating factors. I think it's going to be more often than not a smaller percentage of our patients that's truly refractory rather than episodic, persistent. Is this really, really refractory? And I think it's a low number, but let's just, for argument's sake, that yes, absolutely, they're compliant. There's no other risk factors. I would really have to take a look personally and say, is there something else going on though? And one of the biggest factors, and probably something I've had experience with, or it's been a competing ideology, would be something neurologic. And so that's where I might consider getting a neurology colleague involved and taking a deeper dive with that than really calling before I really call something refractory, because I think it is really going to be a less common case, to be honest.
Yeah, I see, when we have a patient with, truly refractory HE, I also want to make sure that we get a good abdominal imaging study to make sure that there isn't, a huge splenorenal shunt. I see probably the most common is post-tips, where they have problems and sometimes, we have to decrease go back in and decrease the size of the tips to address that. But I think that, but fortunately I don't think adherence is, the major player when it comes to the truly refractory HE. I think especially when you're adding, when they're already on lactulose, they're already on rifaximin. So you got to kind of look out for the other, red herrings, and their clinical situation.
And just to dovetail, Dr. Reau and HoChong, you can speak to this too. When it comes to splenorenal shunting, how often are you evaluating for that? I mean, our patients they always have imaging. So, it's not that you necessarily have to go after that. But, again, argument's sake, they haven't had updated imaging. How often are you evaluating for that? And in what setting? And how often do you maybe pursue embolization? I'm just curious on that.
Yeah. So for us, it's very infrequent. This is your patient who is incredibly adherent. They're maybe taking 5-6 doses of lactulose a day. They're maximized on secondary therapies. They might have a lot of other signs of portal hypertension. And then we're doing cross-sectional imaging to figure out if there's something else that we can do. And they're generally repeatedly hospitalized, or that they call and they're like, I'm they go from mildly confused to in a coma, like instantaneously. It's just that they're very brittle for their HE. Chunk, same with you?
Yeah, I completely agree. They should be already getting, ultrasounds for HCC screening, but, it's when you have somebody with persistent or refractory, I do get a good dedicated, CT or MRI just to make sure, that they don't have a large splenorenal shunt. Problem is that when you find it, there are few people that you actually want to embolize, right? Because, these are patients with intermediately high, MELDs, greater than 18. Those are the ones that, often have, or their MELD is creeping up, the 20s, or the low 20s. And so, that you can't really you can't offer an embolization even if you wanted to. And also, just like the session that they discussed, that's not, it's not reproducible as far as the reporting of the splenorenal shunt, because often they refer to as collaterals. But if the situation is puzzling, I do go back to the radiologist and I'm like, hey, can you take a look and can you tell me so at least I can have something to explain the refractory HE, and not focus more on the the non-adherent adherence, because especially when I have patients that are like, no, I'm taking it, I'm having 2-3 bowel movements a day, and am I pushing having like 3 to 4 bowel movements and risk dehydration. So I think that's a good it's good to know if it's present.
Perfect. So it's always important to leave with the remembrance that any form of decompensation is a time where you should start to talk about transplant, start to talk about long-term goals. And new decompensation can be something like liver cancer. And so to make sure that all that imaging is up to date. I now want to look at surgical risk stratification, because this is a really common question that we get. Sometimes we get it as the person is going to the OR, which is a little bit frustrating. So we like a little bit of warning. But I'll start with you, Jen. How often are you seeing patients and you're asked to clear them for surgery?
I want to say at least several times a month. And it's usually from either neurosurgery, general surgery, that because they want to do a cholecystectomy. In cases like during the transplant evaluation, when you have to evaluate and then that a patient may need a TAVR, that's also something that is common. But I think that is more frequent and is becoming more frequent as, we're seeing, other etiology rising, as to the top of, decompensation in the United States other than hepatitis C. So I actually, I probably get about 3 to 4 consults a month, It's easy when they're, compensated cirrhotics, but, when they start to decompensate, the question is it safe, or, it's that clearance. And I really like Dr. Kim's answer about it's not really just a black and white yes or no. And I think that he really summarized that very well as far as, this is the 30-day risk of, death, and, how could I help you optimize it, but, and support you if the surgeon does elect to, to pursue their, surgery.
So, Christina, we're not giving clearance anymore.
Right.
We're giving risk stratification. How do you approach that patient that's been referred to you for assistance with surgery?
Yeah. So I just had a patient earlier this week actually want clearance for dental surgery. And while we know cardiothoracic or intra-abdominal being one of the more of the high risk, I've had some, dental can be pretty complicated. So it's, don't take that lightly for sure in a cirrhotic. So an established patient, of course, but we kind of have the same thing where, there's never a scenario where we can give clearance. We try to assist and optimize, that patient as much as possible. But I think, we all talk about the child view and the MELD, but we know that can overestimate risk at times. So Mayo risk score or vocal pen can be very helpful for, risk scoring. I think a lot of what we talked about in the session or what was talked about in the session is what we try to do as well. When was their last endoscopy? Where are they at with the, clinically significant portal hypertension? What, updated blood work, minimizing risk factors, making sure, their sequela of, decompensation is well controlled. I think having an updated echocardiogram, where are they at cardiovascularly? So trying to put all those pieces in together and approach that patient from that multidisciplinary standpoint. But again, I think you kind of have to take the whole picture and what is the need. If there is obesity, we've talked about, is there some place for bariatric and endoscopic intervention that can be done beforehand. In the rare case tips, I'd love to hear from both of you how often you might consider that. What is the urgency of this surgery, for their long-term mortality, morbidity? You think about, I have a patient right now who has some pretty significant mitral valve, just like the case was brought up today, regurgitation and insufficiency, valvular insufficiency that may be in the future. Needed a TEE, so we needed to have an updated endoscopy, make sure there were no active varices before we cleared even to have the TEE. So they're in the middle of having that evaluation. So curious about tips and what the two of you, would say to that.
Well, I will, for the listeners, you do not need an upper endoscopy in order to do a TEE. It is not that much different than the size of your food you're eating. We have studies on that. Not that we are not asked for that. But HoChong, let's go back a step. So Christina threw out a number of terms here. MELD score is very well established, as is your child Pew score, but your vocal pen score pulls in some other factors like the type of surgery, right? So I agree with you. I think dental surgery is often discounted. I had a patient die of aspiration from huge bleeding and packing after their dental surgery, and so it is not a low risk surgery. But we do recognize that there are some high risk surgeries. When do you start to worry? What kind of surgery that you're sent for clearance makes you nervous?
The intra-abdominal one, especially when patients have ascites. It's interesting, I think it's easier to write my note and kind of go over, the whole picture of the patient, looking at their CTP, their MELD sodium, and looking at the vocal pen and the Mayo risk. I find it more challenging in really discussing with the patient because, the surgeon's going to get my consulting, my note, but is really explaining to the patient what their risk is. And like Christina said, the importance is this really an elective procedure versus something that's semi-urgent? I think that when there's a lot of discomfort, especially with gallbladder disease and they want their gallbladders out but it's often challenging to really, it's easier when the surgeon gets my note, but it's really difficult to, really have the patient understand their true mortality risk, when they're considering, undergoing, elective procedure, especially when it has a huge impact to quality of life on those patients, right? And so I often find that more of a challenging, discussion than, writing my note. But definitely for someone that has, a little bit of ascites, they want to, have their gallbladder removed or they want their, also umbilical hernias, when they have ascites and,
the big one.
and they may not be a transplant candidate or their MELD is, higher where, they're not a TIPS candidate either, right? And so, but those cases make me very, very nervous.
Well, so you and Christina have both talked a little bit about TIPS. There's data that show in people who have pre-existing TIPS, not TIPS placed for surgery, that patients who have had a TIPS have a lower risk of decompensation after abdominal surgery, not limb surgery, but abdominal surgery. And that leads kind of to the next, breath, which is, well, maybe I should do this to reduce surgery. And it's important to say that guidelines clearly state that we should not be placing a TIPS to make a person a better surgical candidate. That does not mean that it is not part of the discussion. So, Christina, I know you said you wanted to hear what we did. When are you talking to that patient about a TIPS to make their surgical success better?
I think, again, I think kind of the idea of that whole picture. If there's a status for that patient where they're really stable, we talk about it gets to a point where the MELD is, is too poor to consider TIPS. I think it's case by case. It's not a common thing that we would pursue, but if there is a surgery that it's a pretty significant long-term risk for them on mortality and morbidity, but they're in a place where there's good stability. And maybe there are other factors, there are other variables that they would benefit from having a TIPS. I think you have to kind of look at that whole picture. That's probably the patient that we would have a discussion around the possibility of making this more successful for them.
So, HoChong, I started by saying it's for abdominal surgery. Christina's added the low MELD component. What else is going to make you talk about TIPS to the person in front of you?
Well, obviously, it was someone that's had, there are benefits for early TIPS, right? Especially with recurrent bleeding and, for ascites. And I think that, or refractory ascites. So I think that, I don't think that we look at TIPS enough, in those settings. And if someone has, a primary indication where we can evaluate them and then they're good candidates for TIPS, and in addition, it's going to help them reduce, surgical complications, I think that that's, definitely But I'm like you said, you don't want to do preventative like a tips, to make them a better surgical candidate, because I think that's kind of the wrong approach. But if they have a primary indication where the tips is actually going to benefit, their portal hypertension, then for sure. And then that's just kind of an additional plus. And that would probably make me sleep better at night too.
So for anyone that didn't get to sit through the lecture, I think that the lectures did outline a patient who had colorectal cancer and needed a colectomy and had ascites. And that was an indication for tips so that it could make surgical resection better. Now, that patient's not going to be necessarily a transplant candidate in this traditional sense. We keep pushing the boundaries on transplant, but, recent cancer is typically not a good candidate, which is why you don't want to take that high meld patient. And I would say that we probably also look at someone who comes in with flood syndrome, where they're leaking through their umbilical hernia. That may not be an emergent surgery. So it could be, but it may not be an emergent surgery. But that if they get recurrent ascites, that hernia surgery is not going to go very successfully. Same thing with the gallbladder. You're not going to do well with a laparoscopic cholecystectomy if you have ascites. And if you need to have the gallbladder out, these are all potential approaches. But we don't want to leave any listener with the thought that they should just willy-nilly put tips in every patient to make their surgical score, lower, and that we are not giving clearance. We're giving risk assessment, even if your surgeon really wants you to clear the patient.
And they do.
Which they do. Yes.
And they do.
So I would also say that don't forget the rest of the patient, right? I think, Christina, you talked about BMI. We don't like to recommend serious weight loss before surgery because remember, protein status, albumin, these are all very impactful for surgical healing. But if you can do careful, smart weight reduction, especially for abdominal surgeries or cardiothoracic surgery, and I would say smoking cessation.
Yeah,
we sometimes forget, but this is really impactful for our patients.
And I appreciate when a surgeon, especially with an elective, and the patient comes back to me for their routine follow-up for their cirrhosis, and they said, well, they don't want to do the surgery until I can quit smoking. And I'm like, thank you. That's fantastic. And that's huge. I think that's a big part of it. Yeah, absolutely.
All right. So to sum it up, elective surgeries are for lower meld patients. Risk assessment is appropriate, and risk reduction is more than just tips placement, but also nutritional optimization, smoking cessation, and other things. We will now move into where probably you are both much better than me, and that's like educational resources. So I find that my patient comes in, I spend 20 minutes talking to them and their family. I think we are all so much smarter. I walk out, the nurse goes in, and the patient's crying, and they're like, they have no idea what you said. They're confused. They don't know what to do next, even though I thought that we had a really good plan in place. So, Christina, how do you address that? Because in my clinic, our APPs are so much better at navigating a patient through the entire trajectory of their care than at least I am. I won't throw all of my partners, in front of the bus, but I will say that my APPs do a much better job than I do.
Oh, that's fantastic to hear. Thank you. Yeah, I think one of the biggest things, especially with a diagnosis of cirrhosis, is the complication of it, just the complexity of it, right? And I mean, any kind of health condition or new diagnosis, it's a lot to take in. And so one of the things that I think is really important is just bringing that patient back in, establishing that rapport, bringing family members in. The extra set of ears is so important. And there's nothing wrong with having, some repeat education and information. And trying to just, have the patient be engaged, not use too many big words, and again, just repetitive. I think handouts are helpful. In the old days when I first started, I would grab a paper towel and I would write stuff out on the paper towel, or I write a homework, for that patient. Inevitably they'd throw it away. So eventually we created a nice, handout that's simply contact information, signing up for the portal, places where I can put much more direct numbers to contact me, and then a section that I can talk about their, things that I want them to specifically go home, even if it's going to be on the prescription bottle, even if it's going to be on the handout, things that I want to highlight for that patient, and what our plan is going to be, our plan of attack, if you will. This is what I'm going to order for you. This is what I want you working at home. Here's when I want to see you back. and just simply something more for them to kind of go home. Because again, it's kind of the deer in the headlights sometimes, bringing them back in early. And that's just kind of from clinic. But there's a lot of resources, that even up to date, GHAPP, things that you can do that are patient friendly, patient info, from the basics to the beyond the basics on up to date, and having those handouts that you can give at that first visit. But a big part of it is having repeat visits, repeating information, and having a family member in there, I think is really important.
So, HoChong, I find that my patients, cirrhosis is a scary sounding word. And in a well-compensated cirrhotic, they don't feel sick. And so some of my cirrhotic patients that are very well compensated think that they need a transplant tomorrow, even though they are very healthy. And some of my patients just don't believe me. They're like, oh, this person's crazy. I feel great. I don't know what they're talking about. How do you approach, or is that unique to me? Do you find that that's also true in your clinic?
Absolutely. I think, we see this all the time. I actually had somebody on the transplant list that was compensated, but they needed a transplant for hepatocellular carcinoma. And they're like, I feel too good. I want to decline this organ offer, right? So I think education is individualized based on the stage of the disease. But I completely agree with Christina, because especially when someone has a new diagnosis, they're only going to listen to maybe about 5 to 7, 10% of what you tell them. So I think repeat education is important. So what I've done is that a lot of the patients don't even know about what cirrhosis means. And so I actually have a piece of paper and I actually draw the liver and what it does. And that it's just like, that is like
what does the liver do?
That is the primary, thing that I start with educating, and what happens when that liver becomes diseased. Handouts, I think, are very helpful. I tend to limit just because I know I'm going to spend some time. But I also want to tell them the things that they can do, right? Because sometimes some people take this, cirrhosis diagnosis, this new diagnosis, as like they're going to die tomorrow, or some that, hey, I feel fine, or they're in somewhat of a denial, right? So, but then what I also find helpful is that I have other interdisciplinary team members that also see the patient. So the next time they also see a dietitian, or, they see, luckily, because of my practice setting, then, I have them see either a kinesiotherapist or a physical therapist, so that they can, maintain good muscle mass and, really talk about preventative, I like the word preventative hepatology, right? And so, but it has to be staged. I think it's really important to incorporate, family members and loved ones, because, I always tell patients that this disease is just not limited to you. It's a huge impact, on your entire family. And so trying to get everybody involved, but, the challenges is also educating them. So, I see a spectrum of how people react to a new diagnosis of cirrhosis. But I think based on, their basic knowledge of, of cirrhosis, that's a good starting point. And it's interesting. I had a patient that we transplanted that I've been following for a long time. They brought me the picture of the liver that I drew them, because they kept it, and said, thank you. They said, sweet. They're like, you can have this liver back.
They have a new one now, right?
Yeah, that's great. That's very cool.
Well, I want to open it up now to make sure that I addressed all the things that you thought were important. Were there other things that were covered that you think are additive? Or have we hit it all?
I think we've maybe hit it all. I mean, that's fantastic.
Yeah, I think we definitely touched on all the highlights of the cirrhosis section. And I think that the take-home message for me, as far as the risk stratification, which I really loved in that session, is what we can do preventatively, to help optimize the patient if surgery is, if they're going to proceed with surgery, and our active role, and getting that patient primed, even though it may scare you, right? And to hope, to lead into the best outcomes for that patient. So I really, like that patient-centric, focus.
Yeah. It's fantastic.
You have a take-home message, Christina?
Well, I kind of agree with that. If we're just sticking to the risk stratification, and especially while uncomfortable, some of the conditions can be, this isn't something that you want to just run right into. You want to tread lightly, and you want to take the time to optimize that patient as much as possible for that surgery. And so if you need to take 3 to 6 months for, smoking cessation, if you need to optimize their nutrition with sarcopenia and get these other comorbidities better controlled, the sequela of decompensated cirrhosis well controlled, we want to take that time and work with that surgeon to get that patient there. So I think that was a big piece too. Yeah.
All right. I want to thank you both. And I look forward to the 5th annual Liver Connect next year. We'll get a little bit smarter every year. But thank you.
Thanks,
Thank you,
everybody.
Reau.